Hello and welcome. We're going to get started in just a moment. We want to give everyone a chance to get um, logged in. Hello, everyone. It's nothing like when technology doesn't, what's the word, cooperate. But we are so glad that you've joined us today. Um, if you would drop your name and where you're joining us from in the chat, perhaps even share why you were moved to join us this afternoon if you're on the East Coast, or morning if you're still on the, well, I guess it's at least noon if you're in Pacific time zone. I am more than thrilled to have this amazing panel with me today. First, many of you saw the bio, hopefully, of those on our panel. But I never think the words on paper do it justice, right? So I'd like to start with our panelists and ask them to share a little bit about who they are, the work that they lead, and why this particular topic meant so much to you that you were willing to say, okay, Marie, we'll log on. So we'll start with Dr. Connor.
Hello, everyone. My name is Dr. Jamesia Connor. I am an OBGYN. I'm a mother of three and the founder and CEO of Diosada. Diosada is an organization that is focused on improving obstetrical and gynecological outcomes for Black women, other women of color. And we do that by focusing in on obstetrical emergencies because our hypothesis and what the data shows is that racism is what leads to these poor outcomes. So we need to design a intervention against racism. Before coming to this work, I thought I would have a very traditional academic career, but it was actually in seeing how women are treated, just witnessing the really disgusting and blatant racism that you see on the labor floor and kind of throughout the hospital. By the end of residency, I just felt compelled to add this dimension to my training. I made a very, you know, I took a very different course. I went to the Harvard School of Public Health, did a fellowship after that in minority health policy, and then founded two organizations subsequently. And the why behind, so there's a lot of whys. And my why has kind of deepened the longer I have been in this work. One is I have seen, I have visualized, I've experienced the deep racism in medicine. Like you can't argue with me that doesn't exist because I've seen it with my own eyes, like too many times to know it's not a palpable and real force. But also after I had my children, um, it just gave me a deeper appreciation for motherhood and for mothers and my patients. And I knew that, there are a lot of things I can do with my educational background, but the one thing that would bring me the most pleasure and fulfillment is helping Black women. You know, both because obviously I have family who are Black women. I have, my daughter, of course. But more than that, I think it's us taking a stand and saying to everyone that we're not going to tolerate this behavior. If you don't respect us, then okay, we'll find solutions around you. And that's, I think that is one of the things that keeps me going, is that we have to support ourselves.
That's very powerful, Dr. Connor. Thank you. Ariana.
Well, thank you. Ariana McGee. I am the CEO and founder of Navigate Maternity. We are a tech-enabled medical device company, and we focus on improving outcomes for moms through the use of remote patient monitoring, hypertension management, cardiovascular management, and now lately, we just branched out into lactation. So breast pumps, any device that a mom needs from the time that she is diagnosed with being pregnant through 1 year postpartum, we are that support. Started the company alongside Thea James, Dr. Alicia Harris, who's an OB-GYN. We all saw that there was an opportunity to do something better for moms. I worked in the med device space prior to starting Navigate for many years. And after having 4 children and almost dying in childbirth with my fourth, I identified that there was something that we could do better for moms. And so alongside my team, we've built out this company. We are now launched here in the Midwest and soon going commercial to consumers nationwide. So stay on the lookout for that. Thank you.
Thank you. Dr. Harris.
You'd think I'd be faster at unmuting myself by now. Good afternoon, everyone. I am Kanika Harris. I am the Executive Director of the National Association to Advance Black Birth. Our vision is a future where Black babies and children thrive in equitable, culturally safe birthing environments. And our mission is dedicated to advocating for Black birthing families by addressing racial disparities in maternal health. And we also work with birth workers, we grow midwives, we influence policy, and we just ensure that there's culturally responsive care and services. And I like to say along the life course, because I am a firm, big believer in preconception health. My background is that I come to this work as a social epidemiologist and someone with lived experience. Also as a survivor and also a stillbirth mom. I have 3 children. I have twins and a 12-year-old. And so all of that, along with my science background, I was working in maternal health before I even became pregnant. And also as a doula kind of brings me to my why today. So thank you so much.
Thank you, Dr. Harris. Zay.
Good afternoon. My name is Zay Bell. I am the executive director of Zeal of Xander. I don't think it's my organization, it's my son's organization that I started 90 days after his death. I watched my son die April 25th, 2018. I did not know that Black maternal health was a thing until it became my thing. I delivered him at UNC Chapel Hill, and at the time in 2018, 806 babies died that year, and my son was one of them. And Black women were 6 times more likely to lose their children. And I did not know that. And so I was thinking, could things have been different if I did? So I went on this journey, and I like to say that the journey started with everything that UNC Chapel Hill did wrong, right? And that the first thing was providing me with a cake box. And so they gave me this cake box with all of this information in it that I would not be able to use. The only thing that I got from that box was a woman asking me, can she have a piece of my cake, when I went to the parking lot of UNC to find my car that had been there for days. And at that time, I recognized that one of the things that we did not have was representation and resources. And so I decided that I was going to bridge that gap. And so I pulled together 31 Black women, including a senator, neonatologists, pediatricians, gynecologists, doulas, everybody that I needed during the time of my son's death, I put in one book. We have been able to get that book out, over 500 copies in the United States. And I continue to advocate for representation, for cultural competency and congruency in care. I am a facilitator, a trainer. I am a demolitionist, and I am a table flipper. I am very proud about being those things. That is who I am.
Thank you, Zay. I want to stop for just a second. A couple of people have raised their hands. I want to make sure you guys can hear me. And then those who've raised your hands, did you intend to, or did you just hit the wrong button? Message me. I don't want to stop, but I just noticed 2 different people now raise their hands, and I wanted to do a quick sound check and make sure there wasn't something technically wrong. Ajua. I want to give honor to your name.
Thank you. Good afternoon, everyone. My name is Adjua Ayasu Greenlee. I am a full spectrum doula and I'm the founder of Lotus Ring Wellness. My journey actually started long before I knew I was going to get here. My mother is a midwife. She studied in the UK, and when I was younger, I would go with her to set up her childbirth and breastfeeding classes, and did not know that that would help me in where I am today. I had my son in 2012, but I had postpartum depression because I had to have a C-section. He was born a week before Christmas. I spent his first Christmas alone in the hospital, experiencing postpartum depression, and I did not know it was postpartum depression. And so eventually that kind of led me to start asking questions about why nobody kind of flagged me for any of the symptoms or anything that occurred. Not only that, I felt out of place having had a C-section because it wasn't the typical birth. And so I started on the other end of labor and delivery as postpartum doula, but I came to realize that we needed to ask more questions in pregnancy and prep women for postpartum in pregnancy as opposed to waiting until the end of it. And so over the last couple of years, I've added to my trainings. I'm also a certified meditation instructor, and I support women in managing the fears and the stressors, particularly for Black women in the community, because we don't talk about them and they're suppressed and it doesn't come up until we acknowledge that there has been trauma. And by then, now we're dealing with many more effects aside from the incident that occurred. So that is a little bit about the work I do. I am a mom of 4. And again, I've had 4 C-sections also. I was not properly informed, but each C-section was different, and it definitely gave me a lot of insight into the work that still needs to be done in the birthing world. So I've been honored enough to work with so many other women who are doing work on one side and I'm on the other side, but we're all working together to improve the outcomes for Black women in the birthing space. Thank you.
Rajwa. So now you guys know why I'm so excited to have this amazing panel, so much so that I forgot to introduce myself. But my name is Marie Boone Clark, and I am founder and executive director of Birthing the Magic Collaborative. We are a 501c3 that has a national focus. We curate virtual education for Black birthing people, not in an effort to replace the amazing people like Ajua, but in an effort to make our community aware of the services like Dr. Connor's phenomenal organization, the tools that Ariana and the Navigate Maternity team have available to connect you with people like Dr. Harris and Zay. So that's what our purpose is today. But I wanted to stop for a moment because something I learned recently was that not everyone understands the truth about the Black birthing person's experience. And so could we stop? And if I don't know who wants to do it, but let's ground our audience in why we even have Black Maternal Health Week, why I feel so compelled to come out of retirement and stop learning how to play golf to have this organization. My backstory is I had been connected to the beautiful Dr. Shalon Irving, and I want to give honor to she and her mother. prior to her getting pregnant and certainly prior to her dying. But I have to say, in the 40 years that I worked in a field where I was in and out of hospitals, I worked for a pharmaceutical company. There was always a caveat that said, oh yeah, Black women die, but there was never a discussion that we were dying at the percent that we are. And then there was always like this footnote that said, well, Black women are dying because they don't have access to, or they have pre-existing conditions, or they don't, or they don't, or they don't. But our beautiful Shalon did. She had the village, she had the education, she worked for the government. So she had, as old folks used to say, that good government insurance. And she still died of a preventable cause after seeing her practitioner 7 times in 3 weeks to say something's wrong. And what stuck with me is Shalon was my daughter. She had the advanced degree. She had a mom that was very engaged. She had a village, and she wasn't heard. And so that's what we hope to do, is to help our audience, our community, our village know when, as Zaid said, turn over the tables, when they're not hearing you, when they're not stepping forward. But let's talk about the reality, if we could, Dr. Harris. What is the reality for Black birthing people?
It is twofold. I always say it's twofold. It's not just the disrespectful care that is kind of in our face and present, but it's also the invisible wear and tear on us from racism and how we show up pregnant. So, I just want to be clear from my research, studying at the University of Michigan, one of my professors was Arlene Geronimus. So I spent a lot of time studying the weathering hypothesis and all the co-founders that were actually not relevant for us. So, when you look at some of the data around weathering, it's not, it's not confounding conditions like hypertension and high blood pressure, eating, all these other things that we think, being overweight. When you look at that compared to white women, all those things kind of fell to the wayside. It was really the wear and tear on our bodies from racism, from the high levels of stressors in our bodies, from the allostatic load in our bodies that came up to become the major difference between how we showed up to pregnancy and how white women showed up to pregnancy. There's data that shows that African women that come to this country have similar birth outcomes as white women, but their daughters, like one generation later, will have similar birth outcomes as Black women. And so with that, there's something about living in this country that is making us sick. And so that's one part of it, right? And the other part that we hear and that we're yelling and screaming about is on top of that, that we're not listened to. And a part of that is because we are blamed for how we show up when we're pregnant. We're blamed for any pre-existing conditions we may show up with. We're blamed for, quote unquote, being overweight. We're blamed for there's something we didn't do. And so there's blame on top of us, on top of not being listened to, on top of what I say, what I also know is when you show up in the hospital and you look, quote unquote, sick as a Black woman, all these additional stereotypes fall on you. Like, when you play that, when you're in there and you're in that sick role, then all of a sudden you must be poor, you must be on drugs. Like, all these additional stereotypes kind of settle on top of you. So it really doesn't matter. So social determinants of health do matter, place and, what you eat, what you do, that all matters. Absolutely. But then the conundrum of it all is when you do have it all, that seems to not matter either. Right? So it's just like, it's just not making sense. The math is not mathing all around in terms of how we're dealing with this. And, maternal health is the predictor of how well we're doing as a nation, as a society. So it just shows that racism all around, not just for especially for Black women, but also for all women in this country, is just making us really sick. So I will just stop there.
Thank you for that, Dr. Harris, because I think that really just grounds, it gives you pause and it makes my heart flutter. And I was about to ask Dr. Connor to talk a little bit about, oh, there she is. Physiologically, Dr. Connor, how does that, when Dr. Harris said when we present the high levels of stress, when we show up to pregnancy, as an OB, what does that look like for you?
So I actually think about the problem a little bit differently. So as you know, like I'm a trained scientist, so I come at this from my engineering background. Um, and so weathering, I think makes a lot of sense when you talk about chronic diseases of aging. Um, that's kind of where I associate weathering. I honestly think the majority of the maternal deaths in this country are because of negligence. I think plain and simple. We take care of young people. Like as a physician, there are a couple like tenets you have in your head, and young people should not die. They shouldn't. It's really, really hard with modern medicine for a young person to have a catastrophic outcome suddenly. Of course, it happens, but that's rare, right? That's why other nations, other peer nations have maybe, like a threefold decrease than us, because sometimes you will have a tragedy that happens that was not preventable. But this is not what we're talking about. And I think that we have to be really clear because um, the medical community likes to obfuscate what's going on by really, by throwing a whole bunch of factors at you. It could be hypertension, could it be this, could it be that, could it be? But what that actually does in practice is it gives you a problem you can't solve. Because as any engineer knows, right, you can only solve a problem if you can simplify it to a few variables. And so I think a lot of it's deliberate. If not deliberately done, then willful ignorance. But I think the things that kill young women, which I consider, people in the reproductive age, those are young women. A lot of that is due to the way that we care for them. Now, with that said, of course, things like, you know, having a chronic medical illness that makes your care a little bit more complicated, that can contribute. But as we all know, we take care of very sick patients. We take care of very sick patients with a lot of complications, and we do it successfully. So we should be able to do it for mothers. And that's why we do, that's why we started Diosada. That's why we're really bullish on what we think the problem is. Because if we're not able to identify the right cause, it is very hard when you think about, demonstrating efficacy in these sorts of outcomes. If you can't demonstrate the right cause, then we're never going to be able to demonstrate an improvement. And so I think, I hope that we will start to understand this better. That's one of our goals. We're going to be in the rooms with moms, collecting that data, understanding how people are talking to them. So we're going to get some of that data to try to understand what other factors might be involved. But I think the number 1, 2, 3, 4, and 5 cause are negligence, racism.
That's powerful. So one of the things, and that leads to a question, I think, something that you bring up, Dr. Connor, is if we've seen both, with Harris have indicated, our lived experiences lead to weathering, which, can affect us physiologically. And then your point about the things that maybe we can't control, which is the racism or how we are treated when we're in the system. But we don't want to scare. Some of these people may be of childbearing age. And so let's talk a little bit about strategies or models that you all as experts have seen that's helped shift the power back into the hands of our Black birthing people, their families, our community? I'll ask everyone that question. So I'll start with you, Ariana.
Yeah, thank you for that. So I think for us, I mean, Dr. Connor, Dr. Harris, I mean, they've outlined, exactly what's taking place. I think for us at Navigate, we try to understand and identify how we can solve it from a healthcare business lens, meaning that there are interventions in every call point that you can think of, whether it's orthopedics or cardiovascular. There's all these different solutions, but yet women's health is just so severely understudied, underfunded, and they're not bringing solutions that are tactical, that actually work for us, right? Even the solutions that you do see, often what you'll find is that it was created by a man, usually a white man, and his whole team are white men, and they've never stepped foot in an OB's office, let alone a Black OB's office, to actually find out what's happening with our most vulnerable women, which are our Black mothers. And I think that's where Navigate saw this differently. So for us, it was around, okay, we may not be able to go in and solve for racism, but let's try to see ways that we can equalize the bias, right? Like how can we make, as Dr. Harris on our team always says, how can we replace that subjectivity with objective data? So, that's how we started Navigate. And the first go to market was our remote patient monitoring system that combined our validated hardware. So our blood pressure cuff is one of the few on the market that's cleared and indicated for use in pregnant, pre-eclamptic, and postpartum women. And while it won't solve for everyone, we can start with this niche, right? And demonstrate that we can solve or mitigate bias in this patient population, and then utilizing the data, utilizing our strategy, which is really going into the community, working with not only the OBs, but mid-levels, community or organization, excuse me, as well as, policy stakeholders. I mean, really going deep. I think for us, we saw that actually made a difference. And so moms were engaged. Additionally, we're a Black women-led company. So when moms go to our website, they are like, oh, wait, these women look just like me. Like, we're vested because we are the women that we're looking to serve. So, I mean, that's how Navigate saw it. It is an elephant. There's so many pieces of maternal health that we're going to have to tackle, that you need a gang of companies, a gang of stakeholders doing it. The question is, or really the goal is, how can we bite at it? And so this is the way that Navigate's biting at it.
I agree wholeheartedly, Ariana, that it takes an ecosystem. For those of you who know, one of my dear friends is Rose Horton, who's a nurse leader, and she hates when I use that word. She's like, that sounds so corporate, Marie, but it's true. It does take an ecosystem. It does take the research that Dr. Harris and her team are doing to inform us. It takes the on the ground tools that and I think that's what excited me when I met you last year was, this is something, because I know my daughter's doctor had suggested, or not suggested, we got the blood pressure cuff. But as my dearest says, I play a doctor on TV. I didn't know if I was reading it right. I didn't know if I was, and so to have someone look over your shoulder and say, oh yeah, this is concerning, or it isn't, would have been such a blessing. So, but talking about being on the grounds and this ecosystem, Zay, I am becoming your fangirl as I learn more and more about your work. And I know, I'd love to hear your thoughts on what's the strategy or model. I know you've gone around the country, you're lecturing so many places. What's something that you've seen that's helping to shift the power back to the hands of Black birthing people?
I think that we have gotten to a point where we acknowledge that nobody is coming to save us, right? Nobody is coming to save us. We have to take responsibility and accountability and learn to strategize, organize, and mobilize. And I think that is what we are doing. Unfortunately, for us as Black women, we work and thrive well in deprivation, and we also work well in the pivot. And so, and that's by that's something that we have had to learn to do. So what I think has happened is that we have taken ownership of the fact that because no one else is going to come and save us, we have to be our community saviors and our community champions. And so I have seen across the country that the centering for pregnancy models are popping up in neighborhoods that are very successful. Listen, we have to alleviate excuses, right? So if you cannot get to a doctor, let's have everybody, a doctor, a mental health therapist, a doula. Let's have all of these people in one place at one time so that, you know, we can bring women together in a communal space to also not only have the support, but also when you leave out, that you will have community support outside, right? Because you're pregnant with other women. The other piece that I see that Black women are taking ownership in the space is that we are creating more trainings, right? Like a lot of white facing organizations contact me to ask me to come and train them. And the first thing that I tell them is that Black people did not create racism. This is not a system that is broken. This is a system that is operating exactly the way that it was supposed to. We are just learning to navigate the space of calling you out on your racism and making you have accountability for the fact that when I come in, I'm not a patient first, I'm Black first. A lot of people do not like to hear that, but that is 100% the truth. I took ownership of the fact that when I came into a space and I did not know about Black maternal health, what I expected was that my provider would know about it, how to manage me as a Black woman, right? And when they looked at my son, she said, he's measuring smaller than we think that he should. We're just going to change his due date by 10 days. And those 10 days cost my son his life, right? Because that is a reflection of what weathering does. Black women have smaller babies. And when I had my son, it threw him into a non-viable category and we had to watch my son die. When he was born, a Black nurse looked at him and said, wow, he's much larger than we anticipated. Do you want us to call the NICU? And his white provider said no. And so what Black people do is we take our grief and we turn it into grievance. And that's what we have done for years. That is one of our strengths. We come together, we make things happen. And I think that is what we have done in the birth space. We have made people well aware that we recognize that this is 100% because you do not think that Black women have honor. We're talking about access to care, but we're talking about access to humanity. We're talking about access to just being to respect, because you don't respect me, because if you did, you would have heard me when I told you that something was going on the first time and you would have acknowledged that. And so I think that teaching and educating Black women is what we have been doing, and we have been very vocal about that, and I think that is assisting us in changing those numbers as well.
Y'all gonna make me start shouting in here. Y'all didn't know my father was a Pentecostal minister, did you? And I just, every time, Zay, I think about the way that was responded and the many, many years that I spent in the NICU, that it's like, when do we not? We're talking about he was 23, 24 weeks, right?
He was supposed to be 23-2 when they changed his gestation to 21-6, which threw him into a non-viable category in North Carolina.
And at 23, I know, we used to call them back in the day, the Cowboys. It's like, give me that 23-weeker because I'm going to make sure it lives.
Yeah.
So,
and he tried. And he lived for 4 hours and 16 minutes without any interventions.
Dr. Connor, I know you are, this is right up your alley.
No, I just wanted to clarify something I said because I'm seeing some comments in the chat. It's not that I believe weathering doesn't have an effect on your physiology. If I could get the physiological link between that and, let's say, hypertension, or increased rates of hypertension, or even maybe IUGR, like the small baby. But that is very different than death, right? Those are very different things. And I would not be starting this company if I thought it was something that wasn't something that could be addressed. And the reason, like what gives me confidence is, one, just my direct observations, but also the data that we have that's the most reliable when you look at it in totality, because none of it's very good. So it's it's the way, because we don't proactively seek it. A lot of it's retrospective. A lot of it's really limited number of patients, limited number of women that they're looking at. But when we look at the things in totality, none of it's hard for me to draw a physiological link to something young Black women are experiencing that causes them to die when they're in childbirth. It doesn't compute for me as a physician, because we can again handle a lot of chronic illnesses. We are trained to have deal with high risk pregnancies, um, but we're making a deliberate choice whether we want to offer those resources to certain patients, and that's a choice. And I think that is what ultimately, at the end of the day, affects who lives or dies.
I mean, I absolutely agree. I do not disagree that for how Black women are showing up into the hospital, we should not be dying. This is what medicine was made for. We have a high level of interventions. We know what to do. Um, I think the problem is that we are showing up so sick and so young. So that is where the weathering part comes in, is that I want to make sure moms have the choice to go to a birth center if they want to go to a birth center. If they want to birth at home, they can birth at home. And that is becoming less and less of an option for Black women in this country, when it should be the norm, because they are healthy enough to have a natural occurrence of a birth that should not be considered necessarily that you're sick or a medical condition, you are pregnant. And so this phenomenon in this country of showing up pregnant and sick, that is also as big of a problem as the racism and the inaccountability. And I want my daughter to have the choice of showing up and saying, she's healthy, she can give birth at home, she can go to a birth center, she can be with a midwife, right? That's how we used to give birth in this country. That was the norm. So the fact that we are in 2025 showing up sicker without the option of being able to have choices for us. And the number one option is you're going to have lots of interventions and you're going to have lots of C-sections, or this is going to be your issue. That's like a huge problem. And we have over 20 years of evidence and data to show why we are showing up sicker. So absolutely, hospitals need to be accountable. Absolutely, we need that care when we're showing up like this. But Erica Gardner should not be 27 having a heart attack. That's just not normal and pregnant, right? We shouldn't accept that as the norm to show up sick. We have students in college that are already, Black women that are already pre-hypertensive and already pre-diabetic. And some are actually very hypertensive. So for the Dr. Connors, we need you. We need you there to show up for those that are presenting this way and to save our lives and to make sure we are being heard. And I am definitely all the way there on that end, because that was my situation as well. And I won't go into all the details. When I share my trauma, sometimes I can, sometimes I can't. Today is just not that day for me. But we absolutely need you there to listen and to fight that battle. And I'm on that side 100%. That's part of my research. But I'm also, my work with birth centers and working with Birth Detroit, my work with midwives, I'm just finding this really odd issue where we're not able to birth in these places as much as we want to. And I want to make sure that we are addressing that end of the spectrum, which really starts at birth, so that we can show up healthier with some options. Like, my goal right now in life is that my daughter shows up presenting healthy in ways that I didn't when I was pregnant.
Dr. Harris, I think you make an excellent point. One of the things we saw when we first started Navigate, and I think Thea from our team is on this call, she can attest to it. When like we first started, the rate was about 1 in 5, and that was per an American Heart Association study that they found. We are anecdotally now seeing in our markets close to 80%. 80% of moms are hypertensive or have risk factors, severe risk factors for hypertension. So we're definitely seeing this rise in hypertension, which we all then know can lead to whether it's hemorrhage or long-term cardiovascular issues. I mean, just kind of like a multitude of issues kind of arise from this core issue around hypertension. So, um, but we're seeing it. We're seeing it rise. And, you know, I would love to get your thoughts because anecdotally, we have thoughts about is it that, you know, post-COVID, there's this, you know, kind of vascular, you know, situation happening with like moms that now has led to, you know, all of these kind of hypertensive pregnant moms, or is it that, you know, is it the diet and that, you know, the fact that moms don't have access to, you know, healthy foods or grocery stores don't exist in high Medicaid patient populations? Like, what are some of the things that you think are leading to this? And Marie, sorry, I'm not trying to steal your thunder. I'm just really like, I would love to get this from Dr. Harris because we're definitely seeing it.
Um, yeah, so I think a lot of things. The diet does matter. We're eating more processed foods than we ever have. And America, you know, we have all these foods that are banned in other countries and we're not aware. So diet absolutely matters. I think just the stressors that we're carrying, um, we're just at a point where just structurally we're learning less and less about our bodies. We are not going to the doctors like later in life. We have young Black girls that, especially in preconception health, like at a certain point when you're a teenager, you just stop going to the doctors because you think you're healthy and you're not getting your blood pressure checked. You're not really aware of what's happening in your body. And these things are just starting to creep up earlier and earlier. I think one thing that we're seeing in the data just around stress and allostatic load is that we carry 10 years more of stress in our bodies than white women do. So our allostatic load looks like a white woman in her 30s, right? And so I think it's a combination of just, you know, you should, when you're pregnant, it's just like, oh, I'm pregnant. And then pregnancy is a stress test on your body. So pregnancy is the number one stress test that's telling you, oh, you know, you may not have really, you may have been on the border before you got pregnant and now you're pregnant. Your organs, everything is working so much harder. And now all these conditions that your body was keeping you comfortable can't keep you comfortable anymore because you're trying to support a baby. So I don't know if Dr. Connor would agree with me on this, but your body is really made to keep you comfortable. So a lot of these things may not show up initially, but then when you're pregnant or at a certain point, your body's like, hey, I can't keep you comfortable anymore. And then everything is just exploding, right? And so I really feel that um, we have to, like, I've been working a lot with younger generations, and they know less about their body than like a frog or a dog or their cat. They really don't know anything about their bodies like we thought. And so I think we have to really start, as you're working on checking your blood pressure during pregnancy and stuff, we have to push this up, right? We gotta push it up and say, hey, not only for pregnant women, because once you're pregnant, sometimes it's a watch and wait situation. Sometimes there's not
Right.
much that can really happen depending on where you are along the spectrum. That's what I was told. I was told,
The preconception is what I'm hearing, that you're saying it's starting even before you're getting pregnant.
mm-hmm.
Yeah.
And then like, you know, let's watch and wait. For me, it was a watch and wait situation. I will say that. It was just like, there's not much we can do for you. We hope we can manage your blood pressure to viability, right?
Mm.
We don't want that situation. So I've been working further upstream with college students, with preconception health, with decolonizing information. For them, we should not know how to take care of ourselves when we become pregnant. That should not be the first time we're picking up a book on what to do when you're pregnant. Like this was like a natural part of our ecosystem, as was said earlier, where when you're a young girl, um, naturally you would have seen a lot of births. You would have known what to do. You would have known how to take care of yourself. You would have known what herbs to take because you would have been into this. And I'm going to bring Ajua into the conversation because she hasn't been looped in yet. But with her mom as a midwife, I think you're a pure example of how that information was decolonized for you to step in and know what that meant for your work and how that set you up.
Thank you. I actually had a point about the difference. So I wasn't born in the US. I was actually born in London. My family's from Ghana and West Africa. And so my mother had experience as midwife over in the UK where it is totally different. I don't know if many people know about what maternal health looks like over there, but it is not like it is over here. And one example I'll give you is I like to share the story. I was visiting London, visiting my family, and I spoke with a gentleman from France. And so I told him what I do as a doula. And he asked me, "Oh, okay, so how you're contracted by the hospitals and they tell you which, where to go for deliveries?" I said, "No, I'm not contracted by hospitals." And he said, "Well, how do people find you?" I said, "It is unfortunately considered like an extra, almost like a luxury service. There are community-based programs." I said, "But I'm not, the hospitals don't reach out to me." And he said, "Well, why is that?" I said, it's not a priority. And then he said, "I've never been to the US, but I have to tell you, that's probably somewhere I won't go because they don't value life." And
Mhm.
that stuck with me. I said, "No, they do not." And even for my mother, when I was having my child, she was, of course, she's worked at Johns Hopkins, she's been in the space, but having her daughter experience all of that in childbirth was eye-opening because she did not say that she worked at Johns Hopkins. She didn't say where she had studied. She didn't say anything at first. But the minute one of the nurses went to put an IV in my or something, and then she asked, "Why are you using that needle instead of something else?" And the nurse kind of tried to dismiss her, and she said, "Why don't you use this gauge?" And so she kind of looked confused. And my mom said, "I used to be a nurse." And she goes, "Oh, okay. Where were you working?" And she said, "Johns Hopkins in Baltimore." And all I remember is that nurse left and never came back, and they swapped nurses. And we were like, "Well, what was, why swap the person? Just improve the care." I don't know what happened. My mom is also African and slightly intimidating, but that kind of stuck with me and we kind of laughed it off. But second time around when I had my daughter, I was at a hospital where my father works. My father is a physician. And immediately when I walked in, um, I guess I was expecting to be treated a certain way, kind of like Zay said, you see a black face first. But I had to put two and two together. It was the same hospital where my father worked. Before they did any of my paperwork at the top, every single document I had was written VIP patient. So I I didn't think anything of it, but I was in the room. I had people check on me. The minute I knew something was off was when, and off in a strange way, they asked me to choose which anesthesiologist I wanted to do my epidural. And at the time, I thought, just anybody that, just choose somebody. So they asked me, so I read the profiles of one, the profiles of another. And the person came and said, "I trained this young man and he's been under my da 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 da, and this is what I do," and gave me his whole like bio of where his education was. And so I looked at one, I think I picked whoever looked nice. And then, they showed me who they were in their pictures and I thought, strange. And so I picked somebody, did my epidural. But it wasn't until later on and I said, why? There was a level of guilt because I said, why should I have that privilege? Is this what they do for everybody? Like, do you treat everybody this way? And do you have them choose things and you tell them this and follow up and check in? Are you feeling this? Are you feeling that? I had my third child, totally different experience. That is what led me to what I do now, is because you shouldn't have to see some type of privilege and then treat me differently. But the odd thing is, in America, Black women who are more educated and have more money, you still are subject to the same treatment. So that is something that's always stuck with me. And I think, Marie, I think you had mentioned before the statistics and facts and figures. Yes, they are scary, but I've had the honor of listening to Zay speak in other platforms. But knowing our history is very, very important because then we're able to, like she said, we have to save ourselves. That's where the advocacy comes in. And because I was born in the UK and my background is from Ghana, it looks a little different. So I had to relearn what Black history looked like in America. And it's very, very different. And I see so many elements of it that play out in maternal health. And it's shocking, it's alarming, it's disheartening, and we have a long way to go, of course. But I think having discussions like this, really supporting programs and having people come together, it kind of helps flip that a little bit. Because again, my mother was used to the UK, where you have, if you, once you deliver, they pair you with another mother that's in your community so that you can support one another and check on each other. And when I explained that to somebody and my mother explained that, they said, that's, no, we don't do that. So they will have a nurse that's assigned to you. She reads your case file and everything. They learn the area that you live in. They provide you with resources. But if there's a single mother, for example, and there's another single mother within a certain radius of her, they will connect you with each other. They'll come and make sure that you have somebody who's supportive of you and your process in postpartum and check on you. They will make house visits. I have a friend who just delivered her fifth baby in London. The nurse came to her house and checked on her, did the vitals, made sure she was okay. They do up to 3 visits. Not a doula, not a business. This is a nurse from the hospital that will come to your house and make sure you're okay. And so just looking at things like that, it's very eye-opening to see the state of where we are in terms of maternal health and particularly Black maternal health.
Audra, I think that you make a really great point, and I'm looking at the chat. I just want to just add to that. I think one of the main gaps as to why we haven't done that, and I see Jackie from actually my team brought that up, is that this is policy based, right? This comes down to what CMS is willing to pay for. And often, we found throughout the country, even though with under, Biden and Kamala, we were able to get what now it's like about around 45 states that have expanded postpartum coverage. We still have this gap around doula and midwife coverage in many states. And so that creates this gap where, yes, we should have these wraparound services for moms. We should be doing these things. But, the reality of it is that our government's going to have to pay for it. And so until we do that, we will continue to have these gaps. And frankly, the way that the administration is currently going, I highly doubt we'll see these kind of services come back.
And just to piggyback on what you were saying, what Audra was saying, I think that we have to take into consideration is that we're in a place where Black women are not reproductive factories anymore, right? We were economic attribute to our country. And so when we stop being that, we stop being, we just stop being. Period, right? We stop being seen, we stop being heard, we stop being tended to. And so redlining is on purpose and it is a thing. We have to take into consideration that we are in a place now where $50,000 used to be a great salary. $50,000 will do nothing for you at this point. And that's why you have to move into locations and environments and communities that don't have a Whole Foods, that don't have a grocery store, that don't have a farmer's market, but they have a Dollar Tree that sells processed food. They have a Dollar General that has a little market inside of it. They have a McDonald's and they have a liquor store, period. And so foundationally, we are not set up to thrive. We're not educated about our bodies and how they function. I have ran, as a community-based doula, I have ran into so many women that did not know when they ovulated and what that was, that it was a disgrace and it was very sad. But I also have to take into consideration, just going back and thinking about my own lineage. My grandmother did not know her mother because she died in childbirth. My mother lost 5 children prior to me, simply because No one noticed except for a white chiropractor that came into a marginalized community that she had a gap in her pelvis. And the reason that I am here today is because he took a white bed sheet, wrapped it around her leg, snapped her pelvic bone back into place, told her to take calcium and come back 6 weeks pregnant. And 6 weeks and be pregnant. She had me and another child after me. So we are not having people that are in our corner that will tend to us, that want us to be successful in pregnancy, that want us to be successful in life, that want us to thrive, because we are no value in this country because we are not producing any more slaves. And that's just the honesty that comes behind that.
It's true.
So
Nice.
I just want to give just a little bit of food for thought, not, arguing with the points here, but one thing I would love us to do as a Black maternal community is how we frame the problem. Because the minute you frame it as something that is not solvable, by the business community, no one's responsible.
That's it.
And so that's why we're very clear in that's why I like to be very clear about what exactly I'm talking about and what my intervention will and will not do. Because that is deliberate, because that doesn't let people obfuscate from responsibility. And that's really what the goal is, because like it or not, we are in our numbers are too small to not at least be able to convince some people of the importance of these interventions. And so that I caution that when we're talking about racism, we don't make it this like big ambiguous thing that no one's responsible for. And we also don't make it so that it's only policy can solve it, right? Because right there, you've eliminated the way that America solves problems, which is the business community. That's why we're for profit. It's not because we want to make a lot of money. We don't make a lot of money. It's not because of any of those things. It's because that's how in the US you solve problems in this country, is through a corporation. And so there's always like a balance between, being right and being effective. And I want to also have us be effective, because up until now, we haven't been effective. One of the things that I always would like raise my hand in every single like class is we've known about a lot of these health inequities for like 30 years, and they're getting worse. Like, what are we doing? Like, and that's weird for me as an engineer, because we are trained to solve problems. But if you are studying a problem again and again and again, and you're never finding a solution, my first thing that I would think is we need to start with new assumptions. And so that's just one thing to put out there. Not, I 100% agree with what everyone's saying, but language is important to communicate responsibility. And the more that we can make Black maternal health tangible, a solvable problem that is not just, oh, I feel so sorry for Black people. They just have, because even that's like the liberal, right? That's a liberal vibe. It's like, oh, but Black people just have so much bad history, and I'll give them empathy, but empathy is not going to solve our problem, right? And so we have to kind of think about what's the next step to get the resources that we need in order to save lives. And that's my priority. How can I actually save lives with the fewest number of resources? And I think we have to be really intentional about how we do that. And we have to be really exact about how we think about how racism translates into physiological mechanisms, because physiology, that's where the intervention will come at. That's the level of physiology. The level of racism it's not something that the people who solve these problems know how to solve.
I just want to jump in and just quickly say about the long game. So say we save Black mothers, say they come in hypertensive, say they come in with these extreme issues, right? Hypertensive, diabetes, whatever we come to the hospital with, and you save them, right? What does the longevity of their life look like? What other kind of pre-existing conditions? What does their life look like for menopause? What does it look like for the rest of their life, right? They're more likely to die of heart disease. They're more likely to die of other conditions. I did have preeclampsia. I'm here, so I was saved by interventions. Um, it's taken me a long time to figure out that balance to get off of medication, right? To get to a place where I am healthy again, to get to a place where I'm here for my children was really important to me as well.
I guess what I just urge people to do is look out. We've been doing this for a while. Look where our country is. We're not closer to those solving those problems. We're further away. And so that's kind of one of the things I think is really, really important for us to just be crystal clear. When something is not effective, when an argument's not effective, when a group of solutions haven't been effective, we need to do something else. I mean, that's just the, I guess the practical engineer in me, is I
I
totally
think
get
no
all the
one,
things that you're saying, but
yeah,
again,
I think no one's disagreeing with your intervention, but it is an intervention. It's not a solution, it's an intervention. The solution has to be taking us out of this paradigm that we have been put in the first place. As long as we stay in this paradigm, in this box, in this medical paradigm, and how we show up and live in this country, there will always just be interventions. So I do want to be clear about that as well.
and
And
I
I want
agree
to
with you,
piggyback
but
on something really quickly. I think that we have to consider our audience as well, right? And so the way that I would talk to someone that is going to be solution based and trying to fund and do something is completely, totally different how we're going to talk to people in the community, because the people in the community have to have plain language. Plain language is they do not care about you.
oh, and I
You
100%
are a
that
Black woman,
I
right?
agree that I
And
agree with
so
that.
how we speak with them is this is how you take care of yourself. This is how you protect yourself when you go into this doctor's office. This is how you need to ask questions. This is how you need to show up. This is how you need to bring in some other person to help advocate for you when they do not hear you. And so I think that we need to one of the interventions would be, hey, let's form together to say, this is how we can save Black women in the community on the community level. Okay, the other solution base is this is how we just show up to individuals that are policymakers, individuals that are doing heat smears, individuals that are funding. This is how we need to sit and we need to have a conversation with them, and we need to utilize this language. But we know that the priority is making sure that the community knows at that level how you save yourself.
And I think also some of those solutions are exactly what you're talking about, leaning into these other ways of knowing, leaning, like you said, the chiropractor, right? Other situations and that are available to us. Ajua said that she does meditation. So all these other things also encompass those interventions and those solutions as well. And I don't want to leave that out of the equation.
But I think it's very different when you're talking about individuals and you're talking about entire populations. Is a different thing. The type of intervention that you do is different. And I agree, I I don't know as myself, like I don't have the skill set to solve the problem of, systemic racism. I just don't have it. I'm not a policy person. Like I don't really like it. I'm not going to be a politician. But what I know how to do is do science, right? And understand how like certain physiology translates into certain outcomes. And all I'm just putting it in as food for thought is when we have a strategy as a community, because we all will rise and fall with each other. Like we're all going to be successful together, or we're all not going to be successful. I just put as food for thought for the community. The way you talk about things, even to the people within your community, is really important to how they can take that next step.
because sometimes we frame these problems as so large, and they're big problems, but that's paralyzing to people. And I think that's one of the reasons. I think we can all agree we haven't made any progress, right? And so my whole thing is, if we haven't made progress today, let's do something different. Like, let's just try something different, because what we know is what we have done before is not working. So
Well,
we should do something different.
yeah. And so I think too, Dr. Connor and Dr. Harris, to like that point, just because I know we're getting to time, Marie, but you know, to kind of tie a bow on it, I think that you guys are both right. I think the last part of it is that there has to be an ROI, right? And the ROI isn't always financial, right, or economic. It's the ROI for the health of our community, the health of our mothers. To your point, Zay, to your point, Ajwa, you guys outlined really well. Like this us, the reality of Black women is going to lie with us, right? The women that are in this room. ROI refers to return on investment. So the ROI means what is going to be the return on investment for doing the intervention or figuring out the long-term gain. Like at the end of the day, we have to be able to produce results for moms. And so whatever we're currently doing, I hear what you're saying, Dr. Connor, it's not working. But I think to your point too, is that we bite it one bite at a time. We eat the elephant from the lens of, to your point, Dr. Harris, we're eating the elephant from this way. Zay, you said it best. Each stakeholder has a value prop. Identify what the value prop is for each stakeholder. And then from there, we start rolling and we're able to bite at this elephant that is maternal health, morbidity, and mortality. But we've got to always keep our eye on the results, right? Like what is actually being produced from all of the work we're doing.
Mhm.
I agree.
Yeah,
agree.
and I absolutely agree with Dr. Connor. So please don't. I see some stuff
Oh
in
yeah,
the
for sure.
comments that I'm dismissing her. Absolutely not. I absolutely agree with her. We need her in the hospitals for what she does. Like everyone on this call, we need, right? This is not a one problem solution. And so that's what I was saying. Maternal health is so complex that everyone has a part to play at the table, right? And Dr. Connor absolutely has that part. I'm just saying it's not the only. That's all I'm saying.
100%. Yeah, I think that's exactly it. Like all of us together move this forward. But yeah, no, this was a great
Right.
discussion.
And
I
I
can already tell
I
that
think
we
we
part
have
two,
to be,
because
but just to that point about we need us all together, all I'm saying is we all need to define what part of the problem, what bite we're taking, because if we don't speak with more specificity, I worry we're not going to be able to get the outcomes that we need. Because again, I'm just trying to think of this. How do you solve other problems, right? Other big problems, how do you actually solve them? Well, there has to be a way that you go from the 90,000 foot to the 30,000 foot, right? To the 10. And that's the only thing I'm advocating for is let's just talk about it a little bit differently. Because I think that different framing might actually help us move the needle further.
well, and thank you, Dr. Connor. I want to react, but I know we are running a little over, and I don't know where people are with their time. There's a lot that's been said here. I make a commitment to creating another platform for you all for us to come back, and because I know some of you have other meetings. I just want to thank you for your honesty, for your deep care that you brought to this conversation today. Obviously, you're very passionate about it. As Ariana said, that we each have a different role, and it's not any one factor, obviously. Thank you all. We will have a recording. We will share the recording with you. We'll share the links for these brilliant women for you to be able to find their respective organizations and follow up with them around the conversation. I so appreciate our audience, and I know there were a lot of comments that we didn't get to. We will keep them. We'll try to convince the ladies to come back for a part 2 in the next couple of weeks. One of the things that came up that I want to do a plug around is preconception and the importance of your health going in. We actually have a workshop this afternoon, later this afternoon. Go to Safer Births Now and schedule to join that, but that is a topic that we want to address. I'm sorry that we couldn't get to all of your questions. This was just so much. We probably should have booked an hour and a half. Next time we will. I know that there's a lot that can be addressed, and I agree with all of you. And not because I'm a politician, but you each have relevant points. Just for me as a layperson, that yes, we have to look at it at a macro level, and yes, we have to look at it at a micro level. And yes, there are some wonderful initiatives that are taking place. And one of the things I want to challenge our audience to do is to think about how you can take this conversation and the things that you learned just today back to your village. We've been talking about, I'm in Phoenix or Arizona, and how can we continue this conversation? How do we create this learning? Because I've been in spaces where literally physicians did not know the history of J. Marion Sims. I've been in situations where politicians did not know the statistics around Black birthing people, and yet on paper they supported the omnibus bill. And so not everyone knows. And so how do we create a learning opportunity? I love Zay's comment about flipping the table, that I love that Dr. Connor is essentially saying the same thing. We can't keep doing the same thing because we're going to continue to get the same results. So how do we learn? How do we share? And how do we make sure that our community and then those who are outside of our community are actually aware of what's going on? And it's not I don't remember who said it's that whole guilt of, oh, Black people have to deal with so much type of thing. So my challenge to you all is set up a gathering in your community, whether it's your faith-based community, your support, your sorority, your book club, your neighborhood circle. Show this as your first meeting. This recording, get the conversation going. We will commit to bringing you part 2 if the ladies will, and I'm good at stalking people, so we'll stalk them. But really have the conversation, sit down and talk about what is maternal health. You would be surprised at how many in a community don't know. How many don't know the experiences that Zay just described? How many that don't know what Dr. Harris just described? How many don't know that there are tools like, I never say it, Sahara, properly, that to me, I would have moved heaven and earth to have Dr. Connors and her team for my one and only child. Because I'll tell you guys, 9 months, fasting, praying. My daughter's husband's is Chinese, his little mama was fasting and praying like she was a Southern woman, because we knew, or she knew after I told her what was at risk. So if I could have had Dr. Connor, I would have been fasting, praying, and eating ramen noodles if I had to make sure that her team was there. But people don't know. They don't know what they don't know. So tell them about Navigate Maternity. Make sure they have that blood pressure cuff. Don't just tell mama to get the blood pressure cuff. And then if her mama's like me and cannot read it and doesn't even know what a 190 over whatever means, give them the benefit. So I'm just going to preach on that one. So we invite you to come back to us this afternoon. All week long, we've got a conversation. We're going to be just as passionate. I'm sorry, those of you who wanted to log on and talk, but we also want to be mindful of the time. So thank you. We appreciate it. We hope to see you all later this afternoon. Thank you, ladies, so much from the bottom of my heart. You just have filled me up, and I'm excited for our community to get to know more about your work. Have a great evening, afternoon, whatever time zone it is for you, and we'll try to see you soon.
Thank
Thank
you.
you.